Welcome to Headcast, your go-to podcast for all things stroke-related. Here we chat about care, rehabilitation, life after stroke, and the amazing innovations shaping recovery. Whether you're a survivor, a carer, clinician, or just curious, Headcast is where real stories meet expert insights, all with a friendly, down-to-earth vibe. We'll dive into the challenges, celebrate the wins, and even enjoy the occasional off-topic chat to keep things light. So grab a coffee, settle in, and join us on this journey. This is Headcast, connecting hearts, minds, and stories in the world of stroke.
Hi, good morning. Well, today's guest is Francesco Inversini. Francesco is a physiotherapist and an educator and an IBTA recognised BOBAT instructor, known for making rehabilitation truly meaningful. And we're going to try and talk about meaningfulness in rehab today. And Francesco's work, it focuses on how the brain learns, how movement becomes purposeful, and how neuroplasticity can shape real recovery. Francesco, welcome to the Headcast. Buongiorno.
Buongiorno. Thank you very much for the invitation.
Hey, you're very welcome. It's lovely to have you here today. I'm going to jump straight in. I think I was really lucky after my stroke in that I had some great therapists, and I know one of them listens to this. That's not the only reason I'm saying it. So Tasmin, I've been told you listen, so you can't pretend you don't, and I do mean you. And I felt that my therapy was really meaningful, more with some than others. And I had some great sessions where, we'd even get the bus together. How do I navigate public transport? Now I'm relearning to walk. And that was really meaningful to me because I don't know if this word translates into Italian or not, but I wasn't being a snob. I've not used the bus a lot. I didn't realise you couldn't even reserve a seat. Can't even get a cup of tea on the bus. It was all news to me. I thought it was like a plane or getting a train. So it was great. And I was getting some hints and tips about how to speak to the driver, about not driving off when I was walking down the bus. But I also had some poor experiences, mainly in hospital, where, some of the therapy I felt was really dull and just didn't excite me, such as how to make a slice of toast or use the washing machine. And I know those are really practical things, but I was trying to get in my mind, well, is this just an exercise? Or is it practical? Is it going to help my muscles relearn? And I've only just started to learn then about neuroplasticity. So my question to kick off today, I was going to ask you, Francesco, was meaningful rehabilitation. What does that mean to you, and how do you translate that to your patients, in terms of how this is going to be a meaningful session?
Very good question.
Thank you.
I think that meaningful rehabilitation has to be referred to the patient. So I have to start from the patient point of view. And for me, the main important thing is, what is your goal? What do you want to achieve after the stroke in terms of functions, in terms of activities? Because there is something that you cannot do in your daily life that you want to achieve or do you want to relearn again. This is the meaningful. It's the meaningful for the patient. And then based on that, I can start my assessment from a clinical point of view and from the functional point of view in order to understand if there is the potential of this recovery.
You've really hit the nail on the head for me then. The word I was going to use was about realistic. And I know I made a comment on one of your posts not long ago. I remember saying to one of my therapists, I wanted to learn the guitar. I want to be better at the guitar. So she was helping me in terms of how, she wasn't a guitar player, but she was helping me in terms of how we could get a position where I could hold the neck of the guitar. But I couldn't play the guitar before the stroke. I was rubbish then, and I guess I was going to be rubbish after. And I guess there is a little bit of realism as well, in terms of actually what a person can or can't achieve. And that must be really difficult for you as a therapist. How do you overcome that for people, keeping what they want to achieve, their goals, grounded in terms of, or is it a case of shoot for the stars and hopefully you hit the moon?
I remember one patient that told me I had a stroke. And when I asked him, what is your goal? He said, I want to go down in the blue slope and ski again.
Yeah.
And I said, well, it's your goal. How can I help you to achieve this? Let me see if you are able to stand up at first. And he was able. If you are able to walk, and he was able to walk in a certain manner, but not in the efficient manner. And I said, here we have the first thing. If you want to achieve a goal that requires more postural control, more information from your vision, more ability for you to coordinate your both legs and upper limbs and the whole body to do a task that is very high level, I needed first to give you more activity or more ability to become smooth in the movement in a level that is now achievable. So it's walking. The first goal is to walking better. We have to start from that. Then when we have walking, we can try to work with move our bar, push the bar and work for a new goal that can be stay on the ski. And then from the ski, move on the ski. So, but, it takes time. And then there is another question. You want to do it properly, or do you want to do it in a way that can give you a reward because you are doing? So it's a different thing. You can do it in the best manner, or you can do it just for you because you are satisfied because you are doing that. Are two different goals. Okay, you want to do it with the maximum of the quality of the movement, or your goal is to play the guitar or stay on the skis and just move something. Are two different goals, but it's possible to discuss with the patient about that.
That's
Of
really
course,
encouraging.
from a clinical point of view, me as a physiotherapist, as a clinician expert in neurorehabilitation, I need to say, I need to identify if there is the potential of recovery, because I must be realistic with my patient. Something is the hope, and something is if we work together based on the lesion, based on the rehabilitation process that you had until today, that you followed until today, based on what you have now in terms of sensor information, sensory integration, postural control and movement control integration, I can say there is the potential to achieve this goal if we work. Yeah.
No, that's really helpful. And I think it's encouraging for people. So I guess some of that is a bit like how do you eat an elephant. So this is doing it in stages, small bite-sized stages, and about getting the technique right rather than volume.
If you mean if there are different techniques?
More that it's not just about learning to walk, it's about learning to walk in the right way. So that I guess the muscles and I guess the brain in terms of its rewiring, you're learning the correct technique. So it's more efficient for the body. You're not putting strains on other places.
Phil, I think that in rehabilitation, there are different approaches that start from different point of view and different starting point. Do I have to ask you to repeat something that you can do using my suggestion to say maybe in locomotion, in walking? I can say, Phil, you need to flex more your hip. Now, you need to flex the hip, flex the hip, flex the hip, and repeat this to help you. Or can I spend the hour of my treatment session to give you the length of the muscles, the connection between the foot and the trunk, to help you to feel this connection, to help you to feel what does it mean to go up against the gravity and stay up when the legs are moving? Or do I have to just tell you, Phil, flex the hip, flex the hip, flex the hip? Are two different approaches, completely two different approaches. One is to create the prerequisites for the movement, for a task. So I need to assess the patient. I need to understand which are the prerequisites that the patient doesn't have in order to help the patient to have these prerequisites and then help the patient to train the locomotion. But are two different stages and two different approaches.
And that must really, I really love that because it must really help with motivation for the patient as well in terms of that approach.
The motivation is essential.
Yeah.
It's essential because if you come to me and I say, Phil, what is your goal? And you say, I like my life, my situation. Yes, my wife said, I have to come to Francesco I have to go to Francesco to do something, physiotherapy, and stretch my upper limb. Okay, so it's stretching. But if you come to me and say, I have this goal, I want to play guitar. Okay, this is something that is switching on my brain because I have to reasoning. Me as a therapist, I have to ask you, is it possible to do that? If it's possible, what kind of connection do I need into the body? Not into the brain, but into the body in terms of, is it the scapula connected with the hand or not? Does Phil has the fingers able to move independently or not? Because if you do not have the fingers able independently, my question from a clinical point of view is, does Phil has a corticospinal system that it works or not? And here is very clinical. I need to investigate that. Okay. But motivation of the patient, it's important because without motivation, I cannot lead anything.
No, and you're left with a bit of I guess I'm thinking of a scale. You've got one end the ability and the other the motivation. And, without the motivation, you can have all the ability in the world, but you're not going to get there. And how much do you have to explain sort of the mechanisms, because that's a heck of a thought process you've gone through there in terms of what you've got to consider in terms of sort of the biomechanics of the patients. How much do you have to explain to the patients, sort of that in detail? And I say that because I get quite frustrated going through the motions sometimes with therapists. Am I moving my leg that way? Why am I, why do they want to see me move that leg that way? What is it they're looking for? And I found it really helpful. It might just be the way I am. I found it really helpful, but I can picture what they're looking for. So I don't want to come out of there being a physiotherapist myself. It's just nice to know. And I don't know if you ever have to go into much detail with patients, whether that helps or not.
It helps in some cases. It depends by the listener.
Mm.
If the patient is, I don't know, it's a mechanic that really understand the mechanics, and I say, yes, but if your scapula is up and your trunk is down, okay, maybe you cannot move the upper limb. And I can explain the biomechanics behind it. In some cases, I have patients that are more with different education. They studied neurophysiology, for example, for other reasons. And I can explain the connection within the brain. But of course, the part of the explanation of the therapist of what I'm doing, it can be part of the treatment. It helps the patient to understand what we are doing, why we are doing that, why it's so important to stop you in this moment and try to feel only the foot and not the whole the whole body movement during locomotion, because I need the foot. If you are improving your foot component now, you can improve your trunk component after. Okay.
Right.
And I need to explain that. Yes, justify my clinical choices and share these clinical choices with the patient. It's important. And I think it's common in rehabilitation. So I know many therapists that talk with the patient and explain why they're doing something. And it's part of the process, of course.
I was speaking about this to somebody not long ago who's going through therapy themselves. And I was saying I was struggling at one point while I was an inpatient in rehab. And I'm trying to think who it was. I was going to say it was a doctor, but actually it wasn't. I think it was one of the nurses who sat down with me, one of the nurse specialists, to explain neuroplasticity to me. Because I got myself into a hole that, this is pointless. I can twitch my finger, but I can't move it. I can't pick anything up. And you asked me to do these exercises every day, and I couldn't see any benefit. So Linda, and I really do hope she listens to this, she came down and she sat with me and she tried her best. And I think she did a great job of explaining neuroplasticity, because I then spent about £50 on Amazon buying books to be delivered. And I couldn't read enough about it, because it seemed to me like a bit like magic. It was a bit hocus pocus that part of my brain could rewire. And so that really helped me to understand repetition and why I might have to need to cross. And I understood it with children in terms of the midline of the body and crossing the midline and helping those connections. I'd learned that a long time ago. So it started, I guess, with no pun intended, to light up my brain just thinking about it. And I was going to ask, how do you explain neuroplasticity to your patients, that makes sense to them?
Well, neuroplasticity, it can be explained with different words. From a scientific point of view, is something explained in literature. There are the neuroplastic mechanisms that are biological. So the reconnection of the connection that we lose after a stroke, because the lesion creates this disconnection, and there is the possibility to reconnect something, or the synapses that can be activated again. And so there are many neuroplastic mechanisms from a biological point of view. And this is something that the patient must know. So it's not that after a stroke, you cannot recover and the situation will be that. After the stroke, you can start to, I can say, relearn something.
Yeah.
From one point of view. But it is sustained from a biological process. Okay. So it's not that you cannot do it. And especially there is a concept that is not clear in the medical field. And sometimes someone say you can learn it within the first 6 months, and after that it's not possible anymore. And it's not true.
No, I was just going to say, I can attest to that personally. It's just not true.
It's not true, because in the first 6 months, the neuroplastic mechanisms from a biological point of view, they are higher, because they have to reconnect. They have to take care about the lesion. Okay. But after, they become normal. And in our life, and all the people, we can learn something thanks to these two neuroplastic mechanisms. So, I'm not a tennis player, but if I start to attend some tennis lesson, I can learn how to play tennis. I'm plastic. Okay. And I'm not more plastic than normal. I'm just plastic. I can learn from the posture. How do I have to place my body? Where is my body in space? What do I have to do? What do I have to do with my knees? And then the movement. Okay. This is a process of learning, the motor learning process. But it is sustained by these neuroplastic mechanisms. And this must be clarified with the patient, because sometimes, so going back to the motivation, there are patients that say, yes, but when I was in the intensive care unit, someone said, you have 6 months, you have to do everything in these 6 months, because after that, everything disappears. It's not Cinderella. So there is not a time that is finished there. The neuroplasticity continued through the life. And then consider that the neuroplasticity or the plasticity is not affecting only the neural process, but also the non-neural components, also the tissues within the upper limb, within the lower limbs, within the trunk. So the muscles, the fascia, the tendons are plastic. And if they are exposed to an exercise, they can respond. If you are not exposed to an exercise, to the repetition, to the problem to solve in terms of task, they start to change their properties. So it means the plasticity is a process that help our body to learn something. And in this case, in the neurological population, in the field of neurological rehabilitation, it means relearn a task or an activity. Yeah.
How do you maximize that for a patient, that opportunity through the neuroplasticity?
You know that there are, yes, because in literature there is a very, very nice paper that explains the neuroplasticity based on the experience. And there are different principles that we have to just follow in rehabilitation. So the therapist has to follow that. The difference is in the dose. So it means if I want to help you to relearn something, it must be something that has a meaning for you. If the salience of the task that I propose to you is not acceptable for you, so if I'm proposing you to doing something that you're not interested to do, cannot help you to recognize anything because you're not interested, for example, then I have to consider your age. Then I have to consider the intensity of my treatment. Do I see you once per week, once per month, or every day for 4 hours? There's a different intensity. So this is the intensity and the exposure to an exercise. Then there is the number of repetitions, for example. But when you go through the concept of the repetition, we need to understand something. What I'm doing, I'm repeating an error, or I can help my patient to repeat something with less error. It means, do I have to take care about the posture and the preparation of my patient before expose my patient to the repetition to help him to learn, and he can learn how to organize his body before and then move? Or do I have to propose to my patient just to repeat? These are two different approaches and two different outcomes at the end.
So am I right in saying, listening to that, there's something about quality over quantity? So whilst repetitions are great, there's something about doing it in the right way as well.
Exactly. Is that, do you want to improve the quantity of the movement or the quality? If you say, I want to play guitar, at first I need the quality, then I can add the quantity. If I start only with the quantity, maybe I can adjust part of the quality after. But you did already many, many, many repetitions.
Okay. But there was no quality.
Exactly. Is that?
But there was no quality before.
So I have to consider that as a clinician. I have to say, yes, if you want to do that and you have to repeat this task, before you need some prerequisites and some part of your body must be connected. Without that, you're just repeating without a meaning, and maybe you can repeat the errors. And the outcome at the end, I don't know.
So I don't know, again, if this translates. We have a saying, you can't teach old dogs new tricks. And it suggests to me, actually, neuroplasticity, you can, age isn't a barrier. Some things do get harder just because we get older, we might get more tired, or physically we might not be able to do some things. But actually, cognitively, we do have the ability to keep learning and adapting. That's certainly true for brain injury, such as stroke. Now, something that happens to me, and they talk about white coat syndrome in hospitals. Somebody walks in, their blood pressure goes up, and they see a doctor. So for me, when I see a therapist, my back hurts, and I realize I'm not sitting straight. What is it you're looking for? When somebody comes in, I was walking into the therapy session about 3 weeks ago, and I realized I was walking different whilst the therapist had come to get me from the waiting room. And I'm thinking, this really hurts me at the moment, but it doesn't look like it. Should I drag my leg a little bit? What should I do? Because he's always watching as I'm walking in. And he'll say something like, I can see your foot's dragging a little bit. And I'm like, oh, spotted it. That's great. That's what I wanted to tell him about. But some days it hurts just as much, but it's not dragging. I know it depends on the patient in terms of what they're presenting as to you, but Is there something immediately you're looking for when somebody walks into your clinic?
It's interesting to hear that you said when the patient was just watching, look at me, I was changing something. Because maybe it's not just watching, it's also observing.
Yeah. Yeah, that's the better word. Definitely is.
Yeah, it's different because I'm observing.
Yes.
I try to say, yes, just take some steps, but you observe. Well, there is something that I have to consider. If you are in my clinic, I observe your movement in that moment. I cannot observe your movement in your real world. I mean, at home, in the environment where you live. Okay. But I work in my clinic. Sometimes I go to the house of the patient, if they are here close to me, and observe how they walk, how they interact with the object, with the environment at home to see realistically how it is. This part of the reduced or maybe understood and contextualized thanks to the relationship that I can create with my patient. Okay, this is important. So you're here. Maybe I can help you. It's only that. So I'm not judging you. I'm not judging your knee, your foot, your hand, your shoulder, and say, here you have a problem, here you have a problem, here you have a problem. One important thing is, yes, we have the list of these difficulties, but if you feel better the hip extension, look at what happens in your upper limb. Is more release. Okay. So is part of the clinical assessment, is part of the functional task analysis. I have to include also the emotions of the patient, but I have also be able, and this is something that I try to explain to my students, be able to identify the potential and show the potential to the patient in the first session. Within the first session, I need to show you that if I change something in terms of a relationship of your body parts, something can change. And it is after my functional task analysis. But of course, I need to observe you, to analyze the body.
You just said a word there, functional task analysis. What does that mean to the layman like me? I could have a guess, but
It's very technical, but in practical is how do you perform a task?
right, okay.
Tasks are easy. Sit to stand, standing, sitting, step up and down the stairs, reaching, grasping, manipulation, walking. These are the tasks. And I can observe how you perform a task, okay? Because there are some constructs in the functional task analysis that are, how can I say, typical for everybody in all individuals. And some of them are, for example, the symmetry in movement, the alignment, the smoothness, the speed. So something that I can recognize, identify, and also measure in movement. The functional task analysis can be very objective because I can measure everything. Okay, I can measure these constructs, but of course, it's individualized because I can observe and assess how you perform this task and not how another person is performing this task. Because if it's another person, it's another assessment and it's difficult to compare the two. But if I'm assessing your locomotion, for example, I know that in the typical movement, in typical locomotion in humans, the highest level of efficiency in locomotion require the symmetrical steps. We are just moving our center of mass from one leg to the other and the other. If one is asymmetrical, our center of mass can drop. It means we are losing the efficiency. So I know that this is typical and I can compare what is typical with your way to perform the task. And based on that, I understand where I can work. But it's easy. It's observation using a structured way with some parameters and construct. And then it helped me to understand what do I have to do with you.
Cute. And talking about you, because you're also involved in education, what does that involve for yourself, Francesco?
I love to teach. I love to teach neurorehabilitation. And I'm a guest lecturer in Luxembourg, in a university, that is UNEC. I started to work there in 2020 in a course that is specifically in clinical reasoning in neurological rehabilitation. I have other collaborations with other university here in Italy, where I teach neurological rehabilitation or neurological clinical reasoning in neurological rehabilitation. And then I teach in Europe and Asia courses for physiotherapists related to the BOBAT concept or neurological rehabilitation in general, based on the quality of movement and qualitative approach. Yeah, but I'm a fan, and I really like.
You can I can tell in your voice and in your face as soon as you talk about it.
Yeah, I like neurophysiology and how to translate the neurophysiology in clinical practice. And maybe this can answer to your first question. How can you make a treatment meaningful in neurorehabilitation is when the therapist really knows neurophysiology and can translate the neurophysiology plus biomechanics plus kinematics in clinical practice and can help the patient to change the movement.
And that really is important. I think it's the same for, I'd say, a wide range of therapies dealing with people with neurological conditions. It's not the same as any other condition. I've got a sore arm or a sore leg, or it doesn't really function the same. But I guess at the base of it, there's not a great deal up with my leg. Yes, the muscles might have lengthened or shortened a little bit, but the damage is up here in my head, which led to it. And that's and I know that leads to a lot of frustration with certainly people I speak to. And it's unfair on the therapist to send to as well. It's a bit like I've seen counsellors and psychologists from pseudo bulbar syndrome. So I cry a lot, but I cry when I should be laughing, and I can't watch films. It's a nightmare. Don't ask if it's a cartoon and there's something slightly sad and it's elevated for me and it's uncontrollable. But sending me to a counsellor who's dealing with people who are depressed, I look like I'm depressed. I couldn't be happier at times. I don't particularly have any low mood anymore. I enjoy my life. I think I've got a good life. But I present as though I'm depressed. I can't stop crying. And the act of crying makes you feel quite low in the moment. But if you ask me how I'm feeling, well, that isn't representing my mood. But if I see somebody who's experiencing neurological conditions, it doesn't distress them even as much as it does if I'm seeing another counsellor. They can get quite distressed by it, that I can't stop crying for the whole session. But I'm not unhappy. But there's a little bit of a light bulb moment when I saw a psychologist who specialised in stroke and neurological conditions. It was just so obvious to her what was up. It's quite a typical presentation. And I think the same, when you talk about therapists having that insight into neurological conditions to be, if they're a physiotherapist in that area, and I think it's quite vital. So and I know every day will be different, but what does a normal day look like for you in terms of clinical practice?
Sorry, I didn't understand the question.
Yeah, what does a normal clinical day look like for you?
Okay, yes. Clinical day is busy. It's busy, but I see different patients, many patients. It depends because not all the days are the same. I'm a clinician that works a lot in the clinic.
Mm-hmm.
Not every day are the same, but I have many neurological patients during the day. And I think you said something interesting before when you said about crying and depression and the mood of the person.
Mm-hmm.
All neurological condition is not easy.
No.
And I see many patients, and all of the patient has a different story with traumatic brain injury, with incomplete spinal cord lesions, with cerebellar damage, with stroke patients, with multiple sclerosis, Parkinson, so different conditions. And, neurological condition is not something that is easy for the patient and also for the therapist sometimes. But I know that we as a therapist and also the other health professionals like medical doctor, the nurses and the psychologists can help these patients in one certain part. And the big work is made by the patient itself in terms of, I can help you to understand better why your upper limb is moving when you are emotions. I can help you and explain why from a technical basis there is this phenomenon, but then it's your life and you have to deal with that. Okay. So I can take part of this heavy backpack and help you to make it more lighter. And every day is this with my patients. From the technical point of view, I need me, but also all of my colleagues that works in neurological rehabilitation. We need to have many skills and knowledge in terms of movement, neurophysiology, postural control, conditions, everything, plus the human relationship that is very important. From my point of view, this is essential and is before everything. And this is important also in terms of science, because what we are doing now in neurorehabilitation is the evidence-based practice. But it's in the evidence-based practice, there are three pillars. One is the patient with his needs. And here there is the relationship between me and the patient. I need to understand what the patient needs. I need to accept and interpret also the emotions and the mood of the patient, because they can be part of the success or the insuccess of the treatment. Then I need to know knowledge. Okay. knowledge and evidence and papers and books I need to read. And then it's the experience. And thanks to this experience, I have to reflect on the relation that I have with my patient and on the evidence and the knowledge. These mix create my clinical practice every day. So I think it's not the schedule that is the problem. Is try to do the best and putting everything together.
You talk about knowledge and experience, then, one comes with the other. How long have you been practicing now as a physio?
I was graduated in 25, I think. So I have more than 20 years, 21 years of experience. And I started immediately to study neurological rehabilitation because I understood immediately that was my way. And then, many courses. Mentorship is essential. It's essential, the mentorship for a therapist. We need to find a mentor, someone that is expert, someone that can help us to understand and connect the things that we cannot see alone. Because in the book is written, but when you see it in practice, it's not easy to recognize if there is someone that, if you do not have someone that explains it, that this is what you see and what you read in the past. Yeah.
You clearly found a good mentor.
Yeah, it's not easy to find, but I found it in the past. Yes, more than one.
And I think it's true from masculine, because I think it is true of a lot of professions, isn't it? That making that leap from education into the practical, what's written in the textbook is true, but actually putting it into practice with people's emotions, and it's very difficult. And you talked a little bit when we were talking about the patients there, and how is it about different moods, and I'm losing my words. Fatigue there, sorry. And what I'm trying to think what I was going to say. I tried to write down everything I'm going to say. And what was coming to my mind was about how, you said for patients, some can get frustrated, is how slow it can feel for a patient, not the therapist, just actually the whole rehabilitation process. We tend to measure it in millimeters and microseconds rather than minutes and hours. So I think what does get frustrating often is people saying to have patience, and you really couldn't have any more patience as a patient. You're willing to try most things, and even a twitch of the finger can take weeks or months for some people. Yet it must give others great satisfaction to see that something's progressing, but it never feels quite enough. I always think the brain's never quite caught up with the change that's taking place. In my mind, I could still ride my bike while I was in hospital. I'd have the stroke, and I remember the horror on the hospital staff face when I was in the gym on the exercise bike, taking my hands off the handlebars and then forgetting that my muscles in my core weren't working properly and then starting to topple off. But my brain hadn't caught up yet, as far as I was concerned. I just moved my legs up and down. I hadn't considered balance or anything. And I did get back on two wheels. And that's where my progression started. Going back to that motivation, that was really motivating me and giving me the drive to go on. Well, actually, I've been able to do a couple of turns and only fall off once today. Maybe tomorrow I can go a bit further and not fall off. So it was a little bit at a time. Now, before I'm conscious of your time, and you've got a lot to do in your day. Before we finish, Francesco, is there anything you wanted to say? Anything you wanted to get over today from a neurorehabilitation point that you would like other therapists to take on board? Is there a message you'd like to leave people? The education certainly comes through, but whether there was one thing you wish other therapists knew or did in this field.
I just to link with your last thought, you said something related to millimeters and the calls that are millimeters. But 1 millimeters plus another create the centimeters and create
absolutely.
Yeah.
I think that's a great reminder.
Yes, it's important because in neurorehabilitation, the therapist and the patient both must be patient. In terms of patience, I need to wait and help you to sustain these changes. But if there is a potential behind that and I can identify it, we can work on that and take the time that we need. Okay. Just to add pieces by pieces. And at the end, you see the picture that is different.
Well, thank you for today. But before I finish, I think what I've taken away from there I've made some notes, was about how rehabilitation really becomes meaningful when it's built around the person. That's what I'm hearing from yourself. And their goals, not the goals that might be in a book or from the therapist, but it's through listening to them. But really, then you get the brain's capacity for change. And your use of neuroplasticity and movement analysis and this hands-on, it can create real lasting recovery, backed up by, I think, constant reflection, knowledge and learning. Because as you said, every patient's different, and if it's a brain injury, we're all impacted differently. The next person won't have exactly the same stroke or MS or Parkinson's is the last one, there's some characteristics that appear across them all usually, but in terms of the individuality, it is all very different. So I've got to say ciao, and I'm not sure what thank you is, but we'll stick with thank you because I know you'll get that. So thank you for your time today, Francesco.